My name is Stefania Bunduk. I'm a specialist in gastroenterology. I'm from Bucharest, from Romania. And together with my colleague and friend, also gastroenterologist at the Center of Excellence in Pancreatic Diseases from Semmelweis University, Aip and Aip, I want to welcome you to the first session of the day when we should cover some challenging topics, which are biomarkers and rare diseases of the pancreas. Therefore, I would like to invite the first speaker of this session to give his talk and present the perspective of the HPSG on autoimmune pancreatitis, Dr. László Czakó from the University of Szeged.
Dear chairs, dear ladies and gentlemen, thank you for the invitation, and especially thank you for the invitation for Peter Hegyi the Old. And well, when I received this invitation, I was not so happy because he asked me to talk about the autoimmune pancreatitis from the HPSG perspectives. And contrary to the other registries, which we had a talk in the past 2 days, the autoimmune registry was started with open rather late, only 2 years ago. And as you see, altogether, there are only 7 patients already included in the registry, and all of them from Szeged. So of course, we know that AIP is a relatively rare disease, but I would say it's not a success story at all. So I decided to increase the awareness of this disease and a little bit recapitulate how to diagnose this disease. So let's start with a case. It is probably the most frequent scenario how we can meet these patients. It's a male patient. He was sent to the emergency room with mild abdominal pain, jaundice, the sign of obstructive jaundice, no weight loss. And in the lab test, it was revealed that the liver enzymes were elevated. So imaging studies was done, and I showed the CT, which revealed a small lesion in the pancreatic head here, and dilated distal common bile duct. So finally, ERCP was done because of the obstructive jaundice, and that revealed that the intrapancreatic portion of the common bile duct was stenotic, and after brush cytology, which turned to be negative, papillotomy and the plastic stent was inserted. The tumor marker CA99 was elevated, and finally the whole story was in a different hospital I didn't mention, and finally it was decided that the Whipple operation should be done, which was performed in that particular hospital. You can see that after the operation, complications arise, bile leakage and another bile leakage when the total pancreas was removed because of pancreatitis, splenectomy, a large part of the jejunum was removed. So a lot of complications. And finally, after 2 months, the patient was discharged with diabetes. And come to the end of the story, that was the histology of the removed pancreas. So it was not a pancreatic cancer as it was suspected, but AIP, autoimmune pancreatitis. AIP, as you can see, a rare form of chronic pancreatitis. In a serious 3 to 5% of all pancreatic adenectomies were performed because of the for AIP because of the mistaken diagnosis of pancreatic adenocarcinoma. The clinical features of AIP and PDAC are quite common, being elderly patients having pain, vein loss, jaundice, new onset of diabetes. The only difference that AIP is often associated with other autoimmune diseases. So how to diagnose AIP? The 5 cardinal features of autoimmune pancreatitis is used to diagnose the disease, namely the imaging, including the parenchyma and the pancreatic duct, serology, other organ involvement, histology, and the response to steroid therapy. I do not want to go into detail because of the lack of time, just show you some typical picture how, for example, the imaging of the AIP pancreas looks like. So this is the ultrasound, the CT, and it's a typical diffusely enlarged sausage-like pancreas that can be seen on both imaging modalities. On ultrasound, the pancreas is hypoechoic. On CT, there is a delayed enhancement after contrast injection, and there is a capsule-like rim, which is caused by the peripancreatic fibrosis. Unfortunately, as you could see in our case, AIP may manifest as a localized enlargement of the pancreas, and this can hardly be differentiated from pancreatic duct adenocarcinoma or mass-forming chronic pancreatitis. This is the MRI picture. It's the diffuse enlarged pancreas, low signal intensity of T1 series, and the very specific is the capsule-like rim. The pancreatic duct. So I would say this is the only indication probably for diagnostic ERCP when we may suspect autoimmune pancreatitis, and it's still included in many diagnostic criteria. So the typical feature, a long or even multilocal, multifocal narrowing of the main pancreatic duct without an upstream dilatation, because if you see an upstream dilatation in front of the stricture, that is more specific for pancreatic duct adenocarcinoma. The only serological marker which is useful in differentiate AIP from other diseases is the serum IgG4 level. You can see that it's not an ideal sensitivity and it's really not specific for AIP. As I mentioned, the AIP is often associated to other autoimmune diseases like sclerosing ductoadenitis or sclerosing cholangitis, just to mention the 2 most frequent ones. And these diseases share the same pathological, histological condition and show a very favorable response to steroid therapy, showing that there is a common pathophysiological background. And noting this, that it was decided that the whole disease is recently called IgG4 related disease, and AIP is only one manifestation of this multi-organ disease. And histology is the gold standard of the diagnosis of AIP. This is the typical picture what we see, a fibrosis which has a storiform pattern, lymphoplasmacytic infiltration, which is localized mainly circumferential around the ductal epithelium, obliterative phlebitis. And if you perform the IgG4 immunohistology, there is an abundant IgG4 positive plasma cells around the epithelium, the ductal epithelium. That was the type 1 AIP I was talking about. There is another type of AIP, type 2 AIP, and the morphological picture of type 2 AIP is quite similar to those of type 1 AIP. The difference is the histology. The typical cells in type 2 AIP is the granulocyte epithelial lesions around the epithelium. There is a granulocyte infiltration, and this type of AIP is not unfrequent in younger patient, in female patient, and there is an association with ulcerative colitis. This type of AIP is IgG4 seronegative, so there is a lack of serum IgG4 elevation and IgG4 positive plasma cells in the tissues. And to be a little bit, to complicate a little bit, until this point, I talked about the acute phase of the disease. So the obstructive jaundice, pancreatic enlargement, and acute pancreatitis. Those are the acute manifestation of AIP. But there is a late phase, and this is very similar to other form of chronic pancreatitis. So in the late phase, pancreatic atrophy, steatoria, diabetes, and calcification may develop. And in this stage, AIP can be hardly differentiated from other type of chronic pancreatitis. And the fifth diagnostic criteria is the response to steroid therapy, because AIP, contrary to other forms of chronic pancreatitis, is a curable disease. So a small dose of prednisolone, which is used to induce the remission, is highly effective. And therefore, this is also diagnostic criteria to check the morphological and serological response after 2 weeks to confirm the effectiveness of the steroid therapy. If there is a poor response to the therapy, we may reconsider the diagnosis. Just briefly show some studies that we have done and published. That was the very early one, already in 2006, when we proved that not only a morphological restoration can be seen early after applying steroid therapy in autoimmune pancreatitis, but also there is a functional recovery. It means that both the exocrine and endocrine function of the pancreas was restored, measured by OGTT and fecal elastase test after the administration of steroid. That was in 2015 when we made the Hungarian guideline about how to diagnose, how to treat autoimmune pancreatitis. So that was already 7 years ago. So I think it's time to update this Hungarian guideline. And a Hungarian multi-center study was done between 2008 and 2011. And altogether, 17 patients were diagnosed with autoimmune pancreatitis, and epidemiological, the clinical picture, the morphological and the histological characteristic of these patients were described and published. I will not go into detail because those pictures I already showed in the previous slides. I mentioned that AIP is a very rare disease, so it's really difficult to study large cohorts. The only way to have a large bunch of patients that if we participate in a multi-center study. So far, this is the largest study about autoimmune pancreatitis. Almost 1,000 patients were included worldwide, and it was demonstrated that steroid is very effective. Almost all patients were cured with steroid in both type 1 and type 2 pancreatitis. And the relapse rate was, that I would say, quite high in type 1 and a little bit lower in type 2 pancreatitis. And this one is another large multi-center study. It was more than 700 patients were analyzed in 40 hospitals. It was an European multi-center study. And you can see the results that there is a spontaneous complete recovery rate, as you can see, but after steroid therapy, the recovery rate is much higher and the relapse rate is lower. This study also showed that higher steroid doses were not more effective than lower doses, and neither was the starting dose duration longer than 2 weeks more effective. elevated IgG4 level independently decrease the chance of complete remission. So it means that those patients should be followed more rigorously, more frequently. And the relapse rate was almost the same as in the previous study. So, ladies and gentlemen, one of my aims was to really increase the awareness of autoimmune pancreatitis and to launch our AIP registry, because very few patients has already included. So I hope that now you think about disease, and especially when you see those typical morphology I depicted, when there is an unknown etiology of mild pancreatitis or just an unknown etiology of hyperamyloidosemia, hyperlipasemia, or there is an associated autoimmune diseases. And my future panel, of course, definitely to input more patients to AIP registry. And Peter, I think we definitely need a basic scientist or a translational researcher who had more time and to be included in this project. Thank you very much.
Thank you very much, Dr. Czakó. Comments?
Congratulations, Laci. And as I can see also yesterday or before, like diagnosis is a key factor. Like if we are aware of pediatric pancreatitis, we can diagnose 10 times more. So for me, always in the unit, when I see a pancreatitis and the patient has bile, for example, I feel myself, well, it's cholestasis, everything, we sort it out, and the patients go home. What do you think, for example, because, for example, if somebody has an autoimmune pancreatitis and it's starting, maybe they have a cholestasis, maybe they have bile stone. So, for example, should we think autoimmune pancreatitis when the etiology is already known for other reasons, either alcohol or bile acid? So, do you know data concerning how often they come with the joint other etiological factors? It's so the same question.
Not at all. Not at all. So if you have a known etiology of the pancreatitis, like alcohol consumption or stone in the common bile duct, now you don't have to think about the AIP. That's for sure. That's what I emphasize. That the etiology is not known. Then we should think about it. It's really a rare disease. So after you excluded the more frequent etiological factor, then it should came to my mind, to your mind.
Kind of as a follow-up on that, I think rightly so, it is the truth that autoimmune pancreatitis gets much more attention lately, but there's also an overshoot. Because nowadays I see that if the cause of pancreatitis is not readily available, the patient is relatively easily labeled as probable autoimmune pancreatitis. And sometimes with very low IgG4 levels, people contemplate this. And what I think is even worse, I want to give some caution about that I see that some people propagate to do biopsies of the pancreas in that case. And I see even doing biopsies in completely healthy pancreases. So there's no focal lesion. And in the focal lesion, I can imagine that you might do a biopsy and look for specific features concerning autoimmune pancreatitis. But it is really something very, very wrong to do a puncture in a relatively healthy pancreas just on the assumption that you want to exclude autoimmune pancreatitis. I think that's one. And second, I fully support your proposal of kind of notion that we need more basic science in this area, particularly the relapse cases. Why is it so that one person relapses after building down your prednisone and the other patient does not? Because in particular, those that relapse, where we have to start all kinds of other medication to try to help them, I think that's a very interesting and an unsolved mystery in autoimmune pancreatitis.
Thank you very much. I totally agree with your first point, and we could hear it yesterday from Enrique lectures, and I also an endosonographer. Yeah, if we don't see anything, we do not puncture. Of course, there should be a mass in the pancreas, and we can aim that and puncture that.
Okay, I have absolutely the same observation as Marco Bruno. There is many EGG4 done without any real reason, without any changes in imaging techniques in pancreas. And the people are getting steroids, for example. On the other hand, the surgeons have different attitude. They see the focal lesion, they operate on it, and then we find it's autoimmune pancreatitis. So unfortunately, it's happening. And not to mention too much, I agree, but maybe when there's focal lesion in pancreas and we suspect pancreatic cancer, it's not bad to check EGG4 in serum, and maybe that will show us something that we may avoid the surgery. And my question is, do you use rituximab in autoimmune pancreatitis?
There was only one relapsing patient, and finally she required rituximab. Yeah, but back to the IgG4 for a moment. It's a very IgG4 by itself is not alone to diagnose aortic pancreatitis. I didn't show the diagnostic algorithm because it's very complex, but IgG4 alone not good.
I understand that, but it's happening.
And it's also elevated slightly elevated in other diseases, for example, in pancreatic cancer.
Let me say that even the most difficult problem that in 45 patients just last month have appeared in the literature, Shari Peter beat actually from Slovakia. So that's quite common. And we had a patient that just left after 10 years of pancreatitis, which was thought to be a chronic pancreatitis, but that evidently it was autoimmune pancreatitis and developed cancer, which is demonstrated by years with the cytology. And the problem is that the pathologists are not very familiar with the problem. So it's very hard to take samples from the papilla. That's a very good place for autoimmune pancreatitis that found the EGG cells and the other figures of the pancreatitis, but it could be already cancer after 10 years. So that's it.
Well, papilla is a good place, but it's good only when the disease is localized to the head. Yeah. So it's around 50% of the cases. And I agree that we should increase the awareness among the pathologists as well. Yeah.
Thank you for this great review, learning a lot from the discussions. I noticed that the spontaneous remission rate is quite high. So do you always have to treat, or are they very symptomatic so that requires treatment?
No, the symptoms are mild, but the remission rate is quite high if you don't treat with steroid. And it's a steroid that means 30-40 milligram prednisolone for 2 weeks. So it's a very small dose without any side effects. So it's always suggested to treat if the patient has symptoms. If there is no symptom, you don't need to treat them.
As I remember, maybe I'm wrong, but like 10 years back, this steroid used to be higher, right? So did that change over the year?
No, it was the same. No.
Different disease.
Probably. We talk about tomorrow.
The only plea you can make for treating these patients, even with relatively mild symptoms, that it's highly diagnostic. If you have a patient who has the typical morphological features you show on CT scan, or even if the patient has liver function disorders, not necessarily jaundice, but giving for 2 weeks steroids helps you tremendously to establish the diagnosis and to get away of all the differential diagnostic uncertainties that a patient might have future on in his disease career. So we tend to be quite lenient with regards to therapy for the patient, of course, but also to set the diagnosis, which in these cases, in the typical cases, is relatively easy because they respond within 2 weeks. And unfortunately, you showed that case where we know that if people would have thought about the disease and would have started prednisone, within 2 weeks, the patient would have responded and the jaundice would have disappeared. Yeah. And of course, that's not to say we have the same cases in analysis. Sometimes things are overlooked, people don't think about it. Surgeons are very trigger happy to operate on a lesion, but it's relatively unfortunate for some people, because you can see how many complications can arise for somebody who didn't deserve to be operated.
Thank you for your comments.
Congratulations, impressive presentation. Short question, how many in your cohort, how many patients or how many percent of your patients had a typical sausage pancreas on the CT scan? Because in my opinion, it is very tricky to see and discuss the sausage pancreas based on the CT scan.
Around 60%, but what do you mean? It's 6.5, 60, yeah, 60. So a little bit more has the typical diffuse like enlargement of the pancreas, and I think it's not so difficult to recognize if you ever heard about it, of course.
Yeah, this is true. Yes. Thank you very much.
Thank you very much.
Thank you, dear colleagues.